Imagine this. A young mother has just delivered her baby. Everyone around her is celebrating, but something feels wrong. Days pass, and instead of getting stronger, she is getting weaker. She looks tired, unusually tired. She tries to breastfeed, but no milk comes. She waits for her body to return to normal, but her periods never come back, and slowly, everything starts to fall apart. This is Sheehan Syndrome. Now, here's something interesting. The word Shaheen in Urdu means falcon, a strong, powerful bird. But in this condition, that strength is lost. Just like a falcon that can no longer fly, the body loses its control. Why does this happen? It usually begins with one major event, severe bleeding after delivery, also known as postpartum hemorrhage, when there is massive blood loss. The pituitary gland, which is very sensitive, does not get enough blood supply, and that leads to damage. Now remember this. The pituitary is the master gland. It controls multiple hormones, so when it fails, everything downstream fails. Let's go back to our patient. The first thing she notices is that she cannot produce milk. This happens because prolactin is low. Then her menstrual cycle does not return. This is amenorrhea due to low FSH and LH. At this point, many people still miss the diagnosis, but the body keeps giving clues. She develops low blood pressure because cortisol is low. She may feel dizzy, weak, and unable to handle stress. Her sodium levels drop, leading to hyponatremia, and gradually, signs of hypothyroidism begin to appear. She feels cold, slow, and exhausted. Another subtle but important clue is hair loss, especially loss of axillary and pubic hair. And over time, the fatigue becomes overwhelming. Now pause and think. A woman with postpartum hemorrhage who cannot lactate, has no periods, and feels extremely weak. That pattern should immediately make you think of Sheehan syndrome. So how do we confirm it? And we start with hormonal testing. And what do we see? Low ACTH, low TSH, low FSH and LH, and low prolactin. This is panhypopituitarism. The entire pituitary has failed. Next, imaging. An MRI of the pituitary may show an empty cella or a shrunken gland. To assess adrenal function, we use the ACTH stimulation test. This helps confirm secondary adrenal insufficiency. And then comes the gold standard, the insulin tolerance test. It evaluates both growth hormone and cortisol response. In Sheehan syndrome, both responses are reduced. You should also check electrolytes. Hyponatremia is a common finding, and if there are signs of excessive urination or thirst. Think about diabetes insipidus. In that case, urine osmolality and water deprivation tests may be useful. Now comes the most important part, treatment. And this is where many people make a dangerous mistake. Always remember this rule. Cortisol before thyroxine. Treatment starts with hormone replacement therapy. First, give hydrocortisone. This is the most important step and must always come first. Only after that, start levothyroxine. Next, estrogen and progesterone may be needed to restore reproductive function. And if diabetes insipidus is present, desmopressin can be given. Now, during stress, such as illness, surgery, or trauma, steroid doses must be increased. These are called stress dose steroids. Regular monitoring is essential. You should check hormonal levels and electrolytes. For patients who wish to conceive, fertility management may include ovulation induction or assisted reproduction. Supportive care is also important. This includes anemia management with iron supplementation and maintaining bone health with calcium and vitamin D, along with bone density monitoring. Now let's bring it all together. A woman loses blood during childbirth, her pituitary gets damaged, hormones fall, her body slowly shuts down. But with the right diagnosis, we know, and the right treatment, she can recover. So remember the key message. Sheehan syndrome is postpartum pituitary failure. It presents with lactation failure, amenorrhea, and fatigue. It is confirmed by low hormones and MRI findings, and it is treated with lifelong hormone replacement. But above all, never forget this one rule. Cortisol before thyroxine always.